Good morning, everyone, and welcome to the California Collaborative for Long-Term Services and Support monthly webinar. Excited to have you all here. We have a very full agenda with some great speakers today, so really excited to jump on in. We're going to have a robust discussion about CalAIM and its focus on older adults and people with disabilities, which I know the Collaborative has been focused on in different capacities and really interested in sort of the revitalization of CalAIM and the proposals that were introduced last year and how that looks a year later and how it will look as we implement. So we have Anastasia Dodson, who's the Associate Director for Policy in the Department of Healthcare Services, who's going to give an overview. And then we have a great reactor panel looking at the perspective of health plans, providers, on the ground service providers, and of course, the consumer perspective. And then we'll have time for Q&A to have the audience engage in that discussion as well. So please remember to use the chat function or the Q&A function if you have questions, or raise your hand during that period. And then we will have a discussion on transportation and some of the issues and potential opportunities that come along with CalAIM and the Master Plan for Aging and all these initiatives that are aimed at really helping older adults and people with disabilities get to the services they need. So we'll have a great panel there as well with John Cunningham and Russell Rawlings rounding out our agenda, and then we'll have time for Q&A there. So great full agenda, excited to see you all on a Friday morning, and we will go ahead and just jump on in. So I will hand it off to Anastasia to kick off this discussion. Welcome, Anastasia.
Thanks so much. Thanks so much, Athena. And you said about 10 minutes, is that right?
Yes. I think that's
okay,
right.
Super. So, and I think you're all probably quite familiar with the proposal in CalAIM and what we have we've put materials on our website. We have the overall CalAIM proposal that includes a number of efforts in Medi-Cal managed care, and that also includes, for of course, ECM in lieu of services, behavioral health, other areas that are important for the overall healthcare delivery system. And then we have within that CalAIM effort, there's a number of components specifically for dual eligibles and that impact MLTSS. And so I'll talk a little bit more about those, but again, I think you're probably quite familiar with that. We have the long-term care carve-in, which will start in 2023, as well as dual eligibles being carved into Medi-Cal managed care starting in 2023. And we have the carve out of MSSP starting in 2022 in CCI counties. And then we have a whole array of changes that are coming for our transition of CalMediConnect to DSNP aligned enrollment that will start in the CCI counties in 2023 and then expand out to all the other counties in 2025. These changes are, of course, in conjunction with the Governor's Master Plan for Aging, which had over 130 initiatives. And some of those, as you're well aware, impact DHCS, a number of them do. And so we've worked hard to make sure there's alignment between the Master Plan for Aging and CalAIM. There are other elements of the Master Plan for Aging. I think we're focusing on CalAIM today, but I do want to just reference, for example, there's a Money Follows the Person, Medi-Cal Home and Community-Based Services Roadmap that will also intersect with some of the work we're doing on CalAIM and in, again, other Master Plan for Aging efforts. So as far as the dual eligibles, of course, you're all very aware that there's a structural issue with a silo between Medicare and Medi-Cal and the funding streams, and not having a single organization accountable for both sides of that. So CalMediConnect addressed that and had a single plan, but CalMediConnect was a sort of a time-limited demonstration. So this DSNP aligned enrollment model allows an ongoing structure that's a platform that's used in other states. DSNPs, as you know, they are a type of Medicare Advantage plan. They have separate contracts with CMS and state Medicaid agencies. There are dual eligibles who can already enroll in DSNPs, and they don't have to enroll in the corresponding Medi-Cal managed care plan. But our goal in 2023 is to have what's called aligned enrollment in the CCI counties, those 7 counties, so that we will have a crosswalked enrollment of the folks who are already in CalMedi Connect into aligned plans on the Medicare and the Medi-Cal side, starting in January of 2023, and then ongoing ability for dual eligible beneficiaries to enroll in the same plan for, and I'll say under the same parent plan for Medicare and Medi-Cal. And we've talked in the work group about how to effectuate some of that enrollment, and we'll be talking in an upcoming meeting in April about plan choice and some of the logistics there of how a beneficiary, or, of course, they may have a family member or someone who's helping them with the enrollment, but how to have them choose a plan and make it as clear as possible when they're going through that enrollment process, either on the Medicare or the Medi-Cal side, and that they don't have to go through 2 different systems, just make one choice, and that'll effectuate the choice across both systems. So we're going to talk more about that at our April meeting, but I think it's no surprise that that's one of the core things that we want to work out. And as we've been thinking about the purpose of that work group and the sort of sequence of things that we as a department and partnership with the health plans and with all of you, we're prioritizing any of the sort of logistics enrollment pieces to make sure those are solid. And then we will also be looking at topics like the model of care that the DSNPs have to make sure that the foundational pieces, the core components of CalMedi Connect are included in those DSNP models of care, crosswalking then also with enhanced care management and how does that fit with what's required by the DSNPs versus the Medi-Cal managed care plans, looking at data sharing and anything else that needs to be effectuated in order to look at those sort of high impact areas, such as transitions into and out of hospitals, into and out of skilled nursing facilities, other types of reporting that would need to be coordinated either between health plans if there is a sort of a mismatch in enrollment, or even within the same health plan, making sure that the data is flowing back and forth if they have 2 different sides of the house for Medicare and Medi-Cal, and making sure that the provider communication is solid as far as what are the expectations, who's coordinating the care, what are the standards, and then data sharing among providers even. So we have a lot of different topics that we want to work through with all of you in that work group series that we've started. And it doesn't mean that all of the topics need to be hashed out in that giant work group either. We're not limited by only that work group. We can have sidebar work groups, discussions on specific topics, and I'm sure that we will. And I know I'm kind of bouncing around, but there's a number of different areas we're working on. And one thing I also want to flag is for the SMAC contract, which is the contract between the state and the DSNP. There are some changes that we'll be making for 2022. We're going to be talking about those at the next work group meeting in a couple weeks. And but then for 2023, that's where we want to make more changes. And so we'll be discussing that with stakeholders and making sure we're hitting the priority areas for 2023. And then we also need to start planning for 2025 when the non-CCI counties will be required to operate DSNPs. And so we want to make sure that lessons learned, technical assistance, and any kind of support that's needed, we're providing that. We're working with all of you as partners and thinking about what should we be reminding ourselves of, what are the lessons learned. And so in this upcoming work group meeting, again in early March, we're going to talk a little bit about what we have done already as far as reporting and data, et cetera. And I know that's a topic we want to talk about here, and trying to make sure that we're being as transparent as possible and that we have, good accessible data, and that if there's more data or more reporting that we want to do, that it's kind of planned out and we know, okay, in such and such year we'll be expanding, and that everybody is clear on what that roadmap would be for data. One thing I do want to flag also, you're very aware that the Medicare portion of the aligned enrollment, that is not mandatory. So again, we know that was a hot topic a number of years ago with the launch of CalMedi Connect. We don't have passive enrollment, but we are looking at how individuals who are already enrolled in Medi-Cal managed care, they can transition more seamlessly when they become eligible for Medicare into aligned enrollment. And then the last topic, which we don't really have much time for, but there's of course a lot of discussion about DSNP lookalike plans. And we're going to, we have changes proposed in our trailer bill that's posted for CalAIM around DSNP lookalikes. And there will be a crosswalked enrollment in particularly in CCI counties, but in some other counties as well, of folks who are enrolled in DSNP lookalikes into true DSNPs for 2022. So we can talk more about that at upcoming work group meetings or here. Let's see. So I hope that was just about 10 minutes. Of course, there's a lot more we could talk about, but how's that, Athena?
That's great. Thank you. I know there's a lot to cover, so thanks for trying to, hit on the relevant points for this specific group. We're really excited to have you here and happy to also have you hang around a little bit while we hear from the reactor panel, and then also have some time for Q&A. We have about 15 minutes for Q&A at the end. So to keep us on schedule, I'm going to hand it right off to our first panelist, our reactor panel, Amber Kemp, who's the Vice President of State Medicaid Policy at the California Association of Health Plans. So Amber.
Thank you, Athena, and thank you for inviting me today to join this important discussion. Health plans are incredibly excited about the CalAIM initiative. We really view this as a unique opportunity for all stakeholders to be working in the same direction to address Medi-Cal members, not just their medical needs or clinical needs, but also their social needs, right? So the opportunity that CalAIM presents is getting everyone on board and aligned that social determinants of health impact Medi-Cal members. And CalAIM presents all stakeholders with a tool set of enhanced care management benefit, the population health management plans, in lieu of services, tools that we can all work towards to improve the care of Medi-Cal members. And that is the opportunity, is that we are all aligned to improve to take a whole person of care approach to care, to improve the health of Medi-Cal members, to recognize that our Medi-Cal members are the most vulnerable residents in California, and they have needs that we need to address, whether that's housing instability and homelessness or food insecurity. There are these needs that exist, and we all need to come together and collaborate to address these needs, to improve the care for this population, and to make our healthcare delivery system more accessible for all. That is the opportunity under CalAIM. In addition, CalAIM really presents the opportunity for everyone to recognize that, yes, there are health disparities, and we really need to address those health disparities together. And that has become even more evident with the pandemic. So health plans are really excited about partnering with the department, enhancing our collaborations, not only with our provider partners, but with community-based organizations, with all stakeholders, so that we can all work together to improve our healthcare delivery system. So I'm really excited to join this discussion. I'm fairly new to CAP, and so I am joining with an invitation to you all to feel free to reach out to me. I understand that CalAIM is a huge initiative. Health plans are partnering with the department very closely to implement, with their county partners and their providers and community-based partners to implement. But should any of you have any outstanding questions, concerns, please feel free to reach out directly, and I'm happy to have those conversations with you and your members. I'm happy to facilitate conversations with the plans. If you're wondering, how are plans going to be learning from, building off of best practices from whole person care approaches and the Health Homes program and CalMedi Connect. And if there are still these lingering concerns that you have, feel free to send them my way. And I'm happy to have that conversation with plans and to come back with plans thinking on those concerns and how they are intending to address those concerns going forward. So we really see this as an incredible opportunity. Plans are rolling up their sleeves right now, working hard to get everything in place. The timelines are ambitious. We recognize that our county partners, our community partners have a lot going on with the pandemic, and the plans are really committed to partnering with everyone to implement CalAIM successfully. So please feel free to reach out. I'm happy to be engaged in this discussion and look forward to all of the partnership that will be taking place over the next couple of years.
Great, thanks, Amber. Definitely lots of work ahead for our plan partners, so we appreciate you being there, and I'm sure folks will take you up on that invitation to do outreach as things get moving along. So moving along, we'll hand it off to Debbie Toth, who's the President and CEO of Choice in Aging, who's going to give us her perspective on some of the items in CalAIM and maybe what more she'd like to see from folks. So here you go, Debbie.
Thank you, Athena. So first I want to thank Anastasia, because if Anastasia was not willing to do this, we would never have had the planning call around it. And I never would have had the opportunity to be in a room with Amber and hear all the words that she just shared with all of you, because I don't know about you, but for me, this moment and this time where Department of Healthcare Services is like, all right, how are we going to do this with the older adult population, with people with disabilities? And how are we going to do it with the health plans and the community-based organizations? Like, all of these are coming together. And I will tell you, Anastasia, we had this, preparatory conversation, and Amber could not be more receptive and spongy and really partnering with us on the concepts about social determinants of health. And I'm thrilled to be in the moment. So thank you, Anastasia, and thank you, Amber. And I want to wish everybody a happy Caregivers Day. Today is National Caregivers Day. So happy day to you. And thank you for all you do to ensure that people can live with dignity in the community on their terms. So we love that. I want to say, I am not coming to the table all roses. I am I have a few thorns, Anastasia, you know them. I'm frustrated at the lack of detail, I would say, around what it really looks like for the consumers, what really are in lieu services, and what teeth are in the system to ensure that those in lieu services are being delivered equitably across all counties for all populations. We know that we have statewidedness issues. We know that we don't have adult day healthcare or CBAS in some areas. We know that we don't have MSSP. We know that we don't have CCT, and I should stop with the acronyms. Okay, adult day healthcare or community-based adult services. So the congregate setting with the health model where we provide activities and therapies, and we don't have those everywhere in the state. We don't have the multi-purpose senior services program, which is nurse and social worker team who work with people who are 65 and older on Medi-Cal to support their plan to continue living in the community. That is not statewide. We have California community transitions where we get people who've been living long-term in skilled nursing facilities and move them back into the communities and wrap them with the support and services that they need so that they can continue to live independently. So all these things aren't everywhere. Care management is not everywhere. Food is not everywhere. Housing is not everywhere, right? And so how do we, what is included so that we ensure that if, like in Contra Costa County in 2018, looking back at homelessness in the aging population, it had grown by 97% at that point, and it is over 100% at this point. And we know that to live in the Bay Area is extremely expensive, but there's a richness of benefits that folks get there. But if they want to stay with a roof over their heads, they may have to move out of the area. And what is the guarantee then that they can continue to live independently if they don't have the richness of services there? So we're needing some more details. We're needing to understand how that works. We're needing to understand how the partnerships for the enhanced care management and the in lieu services and how those things tie together to ensure that those programs and services exist and that they meet the needs of the people who need those programs and services. So I will say that's my, I feel like the folks who utilize the services and the folks who provide the services weren't in on the designing part of CalAIM. And we want to definitely be in on the implementation part of that. And to the extent that we can participate in a meaningful way and see that what our recommendations are and what our conversations are actually live and move into the implementation phase of it. So Athena, have I gone on too long? I'm sorry.
No, you're good. I'll stop you. You have another minute or so if you want to add anything.
Okay. I am sorry that I popped on the screen for everybody and in the middle of Anastasia's presentation. This is my 4th Zoom of the day. It's crazy right now. But I do. I think what I really want to ensure is that in CalAIM and in the work that you talked about, Anastasia, with the interplay of what's happening with the master plan for aging and what's happening with home and community-based services and all these crosswalk issues, that we are with you, that we can provide the boots on the ground and not just policy wonks, right? So I'm not coming to this as a policy wonk. I have had to do policy advocacy because the services that we provide are constantly at risk, but that's not my space. Really, my space is really being the voice of what it looks like, boots on the ground, trying to implement these things, and to have the voice of what that looks like for us on the ground as providers, and to have the voice of the folks who are utilizing services, that those really need to be at the tables as we're unrolling all of this, as we're implementing all this, and as we're considering how they interplay with each other. And I want to thank you too for the commitment to keeping the data transparent, because this is one of our frustrations. I will just share with you. We don't receive enough money in the community-based adult services space or the multipurpose senior services or California community transitions to do any kind of data tracking. We have not enough money to provide the services, so we have to fundraise to provide them, right? So we need somebody who's going to be collecting and allowing us to see that efficacy and where we are having cost savings and where we can invest more money to have better outcomes. And, so I really appreciate all that. And I think I will go ahead and stop now. Thank you for the opportunity to
I didn't
speak.
even have to cut you off, Debbie.
I saw you unmute yourself. I took the visual cue.
That was great. Thank you for that. And really helpful, thoughtful comments on sort of where we need a little bit more detail and information. So thanks for sharing that. Next, we'll move on to Anna Acton, who is the Executive Director of FREED, who will give us an overview from her perspective of what is in CalAIM and how it will impact her organization, and what pieces she would also like some more information on. So Anna, I'll hand it to you.
Well, thank you very much. Good morning. So just want to start by saying this is, a lot of us have worked in this aging and disability field for many years. And a lot of the pieces in CalAIM really are an opportunity, right? That we've been kind of pushing and advocating for around, looking at the whole person, about going to a value-based system, about the important critical role that social determinants of health programs play into health outcomes. And there's a lot of talk about person-centered services in CalAIM. What we know is that the systems throughout the state are very siloed, right? CalAIM talks to this. We have aging, we have disability services, that are basically a patchwork throughout the state. So I serve 5 counties, some of them very rural in Northern California, right? And Debbie spoke to it a little bit, but there really is a patchwork of long-term services and supports throughout the state. So one of the big questions is, how do we get for where we are to where we need to be to realize that vision in CalAIM? We really need to look at that. We talked a lot about it in the master plan on aging, and that work that we did about how do we get these services consistent throughout the state, whether we're talking about assisted living waivers or MSSP or aging and disability resource connections, which is one of the pieces that I want to speak to here. So I think that's one of the challenges is, you know, in lieu of services and the enhanced, let's see if I say it right, the enhanced care management pieces of this are really critical parts, right, for both the aging and disability population. So we talk about enhanced care management. What does that actually look like? How do we ensure that that system is actually person-centered and culturally competent, I guess, to the target population, in this case, those with significant disabilities and older adults. It's really easy, we've seen this over the last few years, to say, oh, we're going to a person-centered system, but what does that actually look like and what does that mean? And how are we leveraging the organizations and the systems who actually understand what that is in an effective way for implementation? The in lieu of services, critical piece. But is that really, it doesn't look like it's required, right? I'm unclear on that piece, yet it's really an important piece, I think, from the local level, from the individual's person-centered kind of perspective on CalAIM. And so how do we work with those existing infrastructures, those aging and disability networks to provide those services? The opportunity here, back to the siloed piece, is that maybe we can get rid of some of these silos. So the silos are not just in what's available locally, but that we don't often look at the functional needs of individuals, right? So why is it that the 50-year-old who uses a wheelchair, who could benefit from a home mod, is not able to get that in California, whereas maybe an older adult could, yet they have the same functional needs? So I think a lot of what I would like to see in this effort is looking at how to kind of bridge some of those silos and really look at the whole person and the functional needs of the individual rather than age and disability type and those pieces. I also just want to mention that there are a lot of, I think it's an opportunity to build the capacity of existing organizations and networks. And so where they exist, we should be leveraging them, and where they do not exist is a huge question in this whole initiative, I think, for us. How do we build the capacity? And Anastasia, you spoke a little bit to that, right? About how, you know, what can we learn from CCI counties? And what about the non-CCI counties? And how do we bring those best practices to those counties and build their capacity? It's going to take some time to do that. And I think the sooner we start working on that, because it seems like it's a few years off, but really that's going to move quickly, I think, right? So the sooner we start looking at the networks and building their capacity, I think the better. And I'm sure I'm out of time, Athena. So we'll leave it there for now. But I also just want to end by saying that, you know, organizations like Debbie's, like ours, like independent living centers, ADRCs, we want to be your partners, right? We want to be your thought partners, implementation partners. How do we make this program actually meet the needs of individuals that's it's intended to serve? So thank you.
Great, thank you. Look at this panel staying right on time. I haven't had to cut anybody off yet. That's always nice. So last but certainly not least, we have Claire Ramsey, who's a senior staff attorney with Justice and Aging, is going to round out our reactor panel, and then we'll move to Q&A. So please, I encourage you to type your questions into Q&A so we can kick that off, but I will go ahead and hand it to Claire for our last reactor panel.
Thanks, Athena. And thanks, Anastasia, for the presentation and everyone else for their reactions. I think a lot of my points you'll hear are echoing what other people have said, but I think I just want to start off by, like, everyone's acknowledged this, but I think it really bears repeating. It's like, this is a big, complicated, ambitious proposal, which is exciting, but I do think it's going to both come with a lot of opportunities, but also a lot of challenges. And part of that is because there are very ambitious timelines and we are still in the middle of a pandemic. So I think, you know, I'm really excited to see the state taking on so many new exciting initiatives, but I do want us to be thoughtful about the fact that sometimes the train can sort of run away before we kind of jumped onto it. So I think that's one thing, is just us being able to move through this logically in order to really process and make sure we're doing things in a thoughtful way. I think for me, the biggest thing I really want to stress is that I think at all stages and all pieces that we're talking about, we really need to think about like, what does equity look like? And, just to be really clear, a lot of that equity needs to look at it from race, from LGBTQ, from language access. So I just want to be clear because, we're talking about older adults and people with disabilities who are already a population who sometimes doesn't get thought about enough within the frameworks of the pieces we're putting together. But I think we want to make sure we're not just saying that those two populations are monoliths. We want to make sure we're like digging below the surface and looking at the equities for different communities. So I think that's going to need to be like really thoughtfully made sure that it like exists in the contracts, it exists in the actual functioning of what providers are providing on the ground, the cultural competency of those providers. So really it goes and what DHCS is doing as a leader in that space. I think, the point to my understanding of all this is really to simplify access and the delivery system for consumers. There's obviously money saving pieces in this and other stuff around how health plans work. But I think from the consumer perspective, what I want to see is that we kind of keep that as a North Star. It's like, how do we make simplified, equitable access available for dual eligible and non-dual eligible populations? And kind of keep coming back to that as we talk about these complicated things. I really think part of doing that is going to be making sure we're learning lessons from CCI and CMC. There were a lot of positive things that came out of that, but there were challenges. And I think and some of the challenges came from really people's ability to sort of modify and make these changes. Some of it within the plan, some of it for consumers to like get their head around what was being asked of them and what was changing. We've brought this up before, but some really specific things. We are a little worried that the D-SNPs are less integrated than CalMedi Connect. And so we really want to think about what that's going to mean at a consumer perspective. And I am nervous when that, people are going to be enrolled in different managed care, that they're not going to understand how and where to access services from and who's paying for what. So just us really being thoughtful about integration in the healthcare space. In terms of in lieu of services, again, really excited to see those getting off the ground. A couple of things I think we need to make sure of. One is, since they are optional, I'm nervous that we're going to get a real spread throughout the state of what people are choosing to offer. And then by the end of it, we'll have no good sense of what worked on a scale in order to scale up to statewide benefits. Because I think, if you don't have enough data to show like, hey, offering this service really made a difference because it ended up being offered to 10 people in 2 counties. I think we're going to be challenged to say and make the case for it being a statewide benefit, even if it seemed really good on paper. I also worry about the counties that are already under-resourced, that in lieu of services really showing that even more substantially. Because like if you have a resource-rich county, they're, I think, going to be much more likely to take up the IOLS services and actually come on board with that. And if you have a community that looks around at the health plan and looks around and says, well, I don't see any resources in my community that could do these things, then those things don't happen. And then the inequities grow larger and not smaller. And then I think the last thing I just want to say, kind of rounding this out, is that, and I think Debbie and Anna were both making this point too, but I think it's really, really critical, which is some of this can be talked about like sort of colloquially and like, we want more access and blah, blah, blah. But when push comes to shove, there's a lot of really, really, really technical stuff that has to happen. Some of it legal, some of it in contracts, some of it, between managed care plans and external providers, and some between the department, and some between with stuff talking to CMS. So I just think the more the department can act as a translator of that information for people, the more it can, listen to the comments it's hearing and start to think about how you actually operationalize those, even if it requires a real jump to very technical language. I think that's going to be hugely helpful. And then to go back and explain like, hey, we made these 4 changes based on your comments. Because I think sometimes, and I understand why, the department wants very technical comments back. And some people, that's a real challenge. So I just think being cognizant that that's not always what people are going to be able to say, even if they're trying to express that desire, that it's sometimes working with the department and managed care to make it happen and figuring out what the technical language has to be. And then I think the last thing is, I will say one last thing, is just the timeline is ambitious and there's so many pieces to it. I do think if the department could put together like a timeline for the older adult and people with disabilities piece, like sort of pulling that section out, and then us being able to drill down on those separate pieces as they're coming up is going to be hugely helpful. So there might be some stuff that's really important, but we can wait till next year, the year after, to really start digging in where this other stuff we might need to dig in like right now. And so I think that framing would also be helpful for all of us so we can get our minds wrapped around all of it. So, and thanks again for the opportunity to talk today.
Great, thanks, Claire. Thanks to everyone on the panel. So now we have some time for Q&A, and not surprisingly, Anastasia, there's some questions for you. So the first question is just about the assisted living waiver, and if with the implementation of in lieu of services and the ability to get reimbursed for RCFEs, will the assisted living waiver be replaced and essentially made a statewide benefit, or do you have any information on that?
Good question, good flag, yes. And so we've had a good stakeholder process around the renewal of the HCBA waiver. And I know that, various options are being considered. I don't have at my fingertips the timeline for the, next iteration of a public document on that. But yes, we're thinking about that. And we know that there's many people who, and it's disparate in different parts of the state as well, where there may be folks waiting in some parts of the state, but not in others, and that it's an issue we want to try to improve.
Thanks for that. We'll keep an eye out for that. I know I've been wondering the same thing. So another question for you, Anastasia, is that a HICAP counselor says there's a really a big disconnect between the ADAP system and Medi-Cal. And they were just curious about making that linkage as CalAIM and MPA are implemented. Do you have any thoughts on that?
Good point again. And we did have a brief meeting with some folks from HICAP a couple of weeks ago, but yeah, and part of what we want to do, it doesn't matter what the venue is, whether it's a big stakeholder meeting or just a sidebar meeting, but we do want to make that connection, even as part of that, new Office of Medicare Innovation and Integration, because yeah, there's more need to talk about enrollment and making sure that things run smoothly even now. So happy to talk further.
Okay, great. And it looks like we have Nina, your hand is raised, so we'll go ahead and unmute you so that you can ask your question.
Hi, good morning, everybody. I have a few questions. I do want to repeat my question in chat, or it's not chat, but Q&A. For adult learners, the graphics are really helpful. All that text overwhelms me. So I would really recommend that you find some kind of creative way to put that into pictures. Because it's not just for me, it could be for even explaining it to potential consumers of the system that want to drill down beyond how does this affect me. I really recommend that. That's the first thing. The second thing is, I know I keep coming back to this, but for those of us who worked on the master plan for aging, we had a recommendation in the LTS subcommittee about 12 core services. And how do we use CalAIM to really start building out the infrastructure for that? That's one, from the meetings we've had with the steering committee, I haven't let that one go. That's the second thing. The next thing I just thought, and I was just pondering how the state is joining the network, and a number of your counties are in the network, the age-friendly network. How do you use that rubric to also really build out that whole picture of how you connect an individual to their community, both their social and medical needs? I'm happy to have some separate conversations and bring in colleagues that know this world way better than me and know how it's being actualized. We already saw this. San Diego, San Francisco, LA are in the network, and they're using that model. So just putting that out there for later just discussion. Thanks.
Thanks, Nina.
Great.
Anastasia, any reactions to that or any of the other
Oh.
panelists before we move to the next?
All good points, and thank you. Excellent reminder about graphics. Yes, and the core services and age-friendly, all great. Thank you.
Marty, go ahead and ask your question. I think you're muted on. There you go.
Yep. I think I got you. Thanks, Anastasia, and everyone else. I have two questions or comments. One is on enhanced care management, which I think is a great step forward in terms of trying to get to the point where every older adult who needs it has access to care management or care coordination. My question is on that one. What are your thoughts on how do we coordinate between this potential benefit, what the health plans are already doing in their own complex care management that might come in Debbie's program in ADHC? Are we thinking of a database or some tool to make sure that those who need it are getting it and don't fall through the cracks of these various programs? And then I want to ask one other question about IHSS, but let's stop and get this one first.
That's a great point. And I'm sure you've all seen that we've posted more documents around ECM and in lieu of services on the website, and we're asking for feedback. But even back to Claire's point about like, yeah, that there's the technical language, but how do we have that discussion or communication about the point, the big point, which you're making, Marty? And I think I'd be curious, Amber's thoughts as well of, do we need, is it a health plan partnership with providers around that? But then of course there's multiple plans in each county. So great point. And I think that'd be a good thing to get feedback on from all of you.
Okay. The second point is very simply with IHSS being its own world, essentially, how does CalAIM envision really getting coordination or true work between the plans and the IHSS agencies and providers, essentially? Could you talk a little bit about that?
Sure. And actually, it's been on my mind. We were talking internally about it this morning. And we know there's opportunities, at least in the DSNP. Well, of course, CalMediConnect has certain requirements on the plans for coordination with the county IHSS offices. And we can include a similar requirement for the DSNPs. But I think we're going to have to broach the topic in such a way as to be clear, okay, there's guardrails, but there is more that we can do. And we should strengthen the requirements for the plans, but understand it's a sensitive issue and not to have the plans determine the, authorized hours, but of course, there's a huge opportunity there that we should take up. And, sometimes it's an uncomfortable conversation, but I think we can make progress there.
Great. We actually have a few more IHSS related questions in the Q&A. So we'll just stay on this topic for a minute. And, beyond just the potential, sort of coordination with the health plans, there's some questions about, in lieu of services, has some, IHSS-like services included personal care and homemaker services, but not IHSS specifically. So sort of how are they going to remain distinct and different? So a member, isn't kind of getting confused about the delivery system. And then there's also some question. I'll stop there and then we'll hit on the second one.
Mm-hmm. Well, again, we have to work out the details, but the idea is that there's, of course, IHSS has a structure well established of what can be authorized, how it's authorized, and that personal care services would be on top of that and not supplanting that. So it sounds good on paper, but of course, when it comes to, whether it's a timing issue, maybe someone is just out of the hospital, maybe the plan, and is that home health or personal care services? Is it temporarily authorized? And then it's a bridge to get them before their IHSS can be authorized? Or is it a long-term effort? And back even to Marty's point, who's working that out? Is it a care coordinator at the plan, or another community-based service that's coordinating with the county IHSS worker, and how much should the state specify that, or should that be the plan that manages that, or does the plan delegate that to a community organization? Love feedback again on how much should the state specify versus delegate.
Could I just add one thing too, Athena?
Sure, please.
I just want to say that I think the more CDSS is a integral part of this conversation, the better this is all going to work out. Because I think, to Marty's point, IHSS just runs as its own completely separate thing, and yes, it's Medi-Cal based, but I think that's like the biggest thing you can say is like, you guys know it gets Medi-Cal, CDSS moves along. And so I think the more that the two departments are working together on this, and that the stakeholders from both sides, because some people really work on both, but some people really don't. But if this is going to affect IHSS and is going to allow for more services for consumers, then I think both sides of the equation have to be part of the conversation.
I think that's right. Thanks, Claire. Go
Can I
ahead.
add a piece as well? This is Anna. I think that we really, this is, I want to go back to the master plan on aging. And when you look at goal 3, initiative 98, we have to think of it of how people enter the system and get the information and then get access to that enhanced care management and then to the lieu of services. And I would caution having the plans take everything in-house and instead look to those networks, to those systems that are being developed on the local level to do this enhanced care management and connect to the lieu of services pieces. Because what you really need is a true person-centered plan as part of that enhanced care management that then is able to coordinate the home mods, the homemaker, whatever it is that individual needs. I mean, the challenge with this is that we need to keep it person-centered. We need to keep it individualized. And so there are entities, there are networks that can help keep it person-centered, and rather than expecting the plan to be all that for everyone.
Yeah, good points. So I know we're going to have a few more questions. I just want to hit on one thing here, a comment about transitioning folks from skilled nursing facilities and sort of a disconnect between getting them IHSS, which I think goes to some of what Claire was saying about maybe, the agencies talking more and thinking about how to build that process into CalAIM where there is sort of an automatic, connection to getting them set up with IHSS. And Debbie, it looks like you have something to add to that.
Yeah, I would say that this is a lived experience. So we provide California community transitions in Contra Costa, Solano, and Sacramento. And in each of those counties, how we get IHSS assessed for somebody we're transitioning out of a skilled nursing facility is different. And it depends on who is operating, not the public authority, but the county system for IHSS assessment and delegation of hours. In Contra Costa, we were able, when we first started CCT in 2009, we actually were able to have a designated social worker. There's 3 different offices, Central, East, and West, that took a fax from us, and they gave, within 24 hours, we had a response, and they went to the skilled nursing facility and assessed for hours. It's by far the best system we've ever come up with. We have not been able to replicate it in other counties, although we have really great relationship now in Solano County. But I mean, we shouldn't have to be having these things where we're figuring it out. Like, it should be prescriptive about, like you did with the NIF-AH waiver back in the day, that there was this wait list for people in the community. But if you were in a SNF, you automatically had access to the waiver. Like, we should be, we can craft these things. And I want to also echo Anna's previous comments. The idea that the health plans would go into the homes and do the kind of work that the community-based organizations do is the same idea if the community-based organizations started coming into the clinics and started providing medical advice in the doctor's office while they were providing care. Like, let's capitalize on the expertises where they are. So thank you.
That's great. So I hate to cut off this great conversation, but we do have more to get to on our agenda. So I'm just going to quickly hit on, it looked like Tatiana had her hand raised and then put in the chat that fee-for-service Medicare does have a chronic care management services benefit. So thinking about how to coordinate with that. And then there is some more questions, Anastasia, about how the in lieu of services works with some of these waivers like the assisted living waiver, CCT, and it sounds like there's sort of more to come on that as you guys examine that. So we'll look for more guidance for you from the state as those go, but happy to help out if you need stakeholder thoughts. You can tell we have a lot here from this group. So I really want to thank you, Anastasia, and the panel for coming. There's clearly a lot going on, right? This idea of trying to move to consistent statewide benefit while still recognizing a lot of this is local, right? And person-centered, and how can it be standard and person-centered at the same time, right? And navigating through all of that, and lots of transitions for our plan and provider and consumers all at the same time. So really, thank you all for your time. Really great panel. I wish we could have a longer discussion. I'm sure it won't be the last. We will continue to use you, Anastasia, as a great resource, and the entire panel also as a really great resource with all the different perspectives. So thank you again. You are free to go, Anastasia, or you can stay on if you want to hear about transportation. So moving on, we're going to talk about transportation, something that came up in one of our work groups as maybe a potential missed opportunity in the final master plan for aging, to really think through some of the ways that we could leverage current resources in the community level to really get at access and transportation for folks in various capacities. And so we're lucky today, we're going to have Russell Rawlings, who's a statewide community organizer from the California Foundation for Independent Living Centers and Disability Organizing Network, talk about some of his personal experience, some of the work he does, and then John Cunningham, the transportation planner for the County of Contra Costa, will give us some perspective of how these resources could be used at a local level. So Russell, I will hand it off to you.
Good morning, everyone. Welcome. And just one moment while we get our presentation up here. My name is Russell Rawlings. I am the statewide community organizer at California Foundation for Independent Living Centers. And I also facilitate the Disability Organizing Network, or DO Network. And we have a transportation work group that actually meets monthly on the first Thursday, or sorry, the third Thursday of every month at 9 a.m. And I'll let John introduce himself as well.
Hello, folks. Here, I'm trying to get my screen share up here. Give me a brief second. I think that's it then. Yeah. Welcome. Good morning.
John, we're not seeing the presentation yet.
Oh, okay. Thank you. Share screen. Okay. Always works smoother in the test than it does in real life.
And let's see if it's not working. Let me see if I can.
I'm almost there. Presentation.
There we go.
All right.
Great, thanks.
Yeah, you bet. Welcome.
We're seeing the presenter side, just FYI, but that's
the presenter side. I'm sorry.
Yeah, with notes and everything. It's yeah.
You go to display settings at the top. I think you can show just the one.
Okay.
Oh.
Display settings.
Oh. If at the top of your screen now, do you see in the middle, it says display settings? There you go.
There we go.
Okay. Worked very smoothly on the test, like I said. Anyway, thank you for having me. My name is John Cunningham. I'm a principal transportation planner in Contra Costa County. Currently, I work as sort of an all of the above transportation planner. I work on a little bit of everything, bike facilities, some legislation, that sort of thing. But earlier in my career, I was the operations manager for a county-wide Americans with Disabilities Act paratransit operation. So that'll be relevant here in a little bit. And then, so Russell already introduced himself. So I'm going to try and give a policy bureaucratic viewpoint of accessible transit. And Russell's going to be providing sort of a on the ground lens through to this service area. Moving into some definitions, the organizers asked that we start by providing some basic accessible transit information and then include some more advanced issues. We're going to touch on the master plan on aging, specifically a mechanism called a Consolidated Transportation Services Agency. It's a bit cumbersome, but that's the agency that I used to work at, and that's going to be, again, relevant when we talk about recommendations and how to make progress. So definitions. Accessible transportation is really a blanket term that we use to describe a universe of services for older persons and persons with disabilities, transportation services. You have your Americans with Disabilities Act paratransit, typically provided by public transit agencies. You have your dial-a-rides provided by cities very often, travel training, teaching people to use rail lines and buses, fixed route buses, that sort of thing. Mobility management, which is a sort of an umbrella term for all of the above. It's, I guess, in the healthcare field, it would be called a single point of access. One call, one click access is what transportation has started to call it. And then you have volunteer driver programs, and then you have nonprofit program specific transportation. You have your, meal delivery, adult day healthcare, that sort of thing. So that's kind of accessible transportation. When we say that, that's what we're talking about. And so when will we see progress? That's the subtitle, and I think that probably needs a little bit of explanation. But before I get into my prepared comments, I heard earlier, the earlier presenters mentioned person-centered and money follows the person type of concepts. And I want to say in transportation, it's not like that. It's a little bit of the opposite, to be honest. It's services structured for the agency and sort of bureaucratic expedience. And the need and the pattern of need is sort of secondary to dancing around the agency needs. And so, again, explanation on when will we see progress. I asked this question, I put it as a title because unlike other areas of transportation that I work in, this area seems to be perpetually studied with little to no implementation of any recommendations. And that's at the federal, state, and local level. The thumbnails that you see here on the screen are just a handful of the studies that have been conducted. I actually had probably over a dozen up before, but graphically it didn't really work. So you see some government accountability office studies on the screen. They've been studying this since the 80s. And they've basically been saying the same thing over again, which we're going to get to here in a little bit. And there just hasn't been any implementation of the recommendation. And again, this is at the federal, state, and very often at the local level. And so I want to give a caveat. I'm generalizing because we're going to talk about a statewide system. And so there are certain successes out there. There are successful agencies, but the goal is to make success systemic and pervasive, not the result of a sort of a local hero at a nonprofit or a one-off victory. It needs to be consistent. And so these studies sort of summarize in this one great quote. And I'm only going to read two quotes that I think are particularly hard-hitting. And this is the first one, and that can be summarized like this. It's pretty dire, but it's accurate. Current senior-oriented mobility services do not have the capacity to handle the increase in people over 65 years of age. The massive growth among the aging points to a lack of fiscal and organizational readiness, the closure and consolidation of medical facilities, while rates of diabetes and obesity are on the rise, will place heavy demands on an already deficient system. So I had a screen full of quotes, but that one sort of summarizes it all. I realize it's a bit dire, but and this is probably no news to this group. I typically speak to transportation focused folks, and they really aren't aware. And so Again, I'm a sort of jack of all trades transportation planner, and I've been able to see the discrepancy on progress in other areas. And I'm going to go through those discrepancies here. You look at roads, we can all see it with our eyes. Roads get improved, lanes are added, system improvements like toll lanes and ramp metering, commuter lanes, those sorts of things. People might argue whether or not those are improvements. Some of them upset people, but the point is there's a regular infusion of planning and investment. That's the point I want to make here. And then you have conventional transit. You get new rail lines being built. We have a new BART line here operating in Contra Costa County. We also have a new ferry service, but there's expansion, there's investment. We just don't see that in accessible transit. It's just stagnant. And then the last one that I want to mention that we should remember here, and that's bicycle and pedestrian transportation. Depending on where you are in the state, we're seeing bicycle facilities pop up, separated bikeways. You got green bike lanes that you see now, and critically, they have a new funding program, the Active Transportation Funding Program, that pays for these facilities. And so, why is progress so elusive? I want to break this down. There's quite a bit of material here, and that's deliberate. The organizers asked that we let this group know how they can make progress, how this group can make progress. And it's critical, I think, that we understand how entrenched the thinking is on accessible transit. And the thinking is what results in the stagnation of this area. And so I'm going to try and go through these pretty quickly here so we can get to the positive next steps part of the presentation. But the first one is probably the obvious. It's the money, and transportation funding is incredibly complex. I'm just going to use this example. In 2017, Senate Bill 1 passed. It was a massive infusion of cash, $5.2 billion a year annually into the transportation system, and it funded a variety of programs that you see here: roads, bike ped projects, conventional transit, and then it even goes down into research, boating, agricultural, parks, transportation programs, and accessible transit received $0. And I do have to say that the conventional transit portion, there are accessible components of that. You have your kneeling buses and level loading trains, that sort of thing, but no specific line item for accessible transit. And that was a huge program, Senate Bill 1. And then what I talk about here is reliance on and deference to public transit operators. And I'm going to quote probably the leading public transit advocate in the state here. And he's correct when he says it, that people expect transit agencies to be everything to everyone, and they just don't have the bandwidth or the funding to do it. They're charged with all sorts of things, low-income transportation, commute solutions. And when we ask them to ramp up their accessible transit functions, they just can't do it. In their defense, they really don't have the bandwidth. And so next item is a bit of an odd one, and that's programmatic separation. And that is that accessible transit is treated separately from other areas of the transportation system. You have your conventional transportation plans where money is divvied up. Well, accessible transit typically isn't discussed in there. They're in a separate plan, these coordinated plans. Even ADA paratransit programs that we're going to talk a bit about later. I know Russell has some commentary on that. Those are separate. They're separated out. And then you have city programs, which are often in the Parks and Rec department, which I get, but again, outside of the kind of transportation discussion when resources are allocated. And then this one, I don't know what it is, but transportation for older persons and persons with disabilities is sort of a strange blind spot, even for advocates. There are several statewide advocacy organizations that very specifically focus on transportation inclusivity, low-income folks, persons of color, other historically marginalized communities, which is great work. I spoke with a friend and colleague who's the executive director of one of these agencies, and I asked, well, you do all this great work, why are the elderly and disabled excluded from your portfolio? And it stopped her cold. She said, yeah, that's a great question. I really don't know. When I started the organization, I asked, and it was the typical, we don't we don't have the bandwidth, we have these other issues. And so even advocates for transportation inclusivity somehow don't see this need. Then you see your 3 studies here. Again, why is progress so elusive? But getting into the specifics of these, they all recommend the same thing, pretty much from the 80s, and that is coordination. And this is understandable to a certain extent. There are so many resources out there on accessible transportation. We really are, frankly, awash in transportation programs. Because they're disorganized, operating in different silos, we have overlaps and we have gaps. So the logical conclusion is to just have these coordinate. But coordination without funding is what I call it's the thoughts and prayers of accessible transportation. It's pointless. It is a meaningless word that gets more meaningless over time. Frankly, there's a great public policy book from the 80s that has absolutely nothing to do with transportation, but it really nails the issue here. I mean, this is only the last thing I'm going to read, but it is very powerful, I think, and that's invocation of coordination does not necessarily provide either a statement of or a solution to the problem, but it may be a way of avoiding both when an accurate prescription would be too painful. And that's what we're going to talk about here in a little bit. What is that? What is that accurate prescription? And somehow I stopped the share. Okay, we're back. Here is progress. So why is progress so elusive? And that is the attitudes towards the Americans with Disabilities Act paratransit programs. I think as Russell is going to talk about at the end of the slide here, there's some unintended consequences, but here are some of the typical commentary. It's an unfunded mandate. Well, it's been 30 years. I think people should, try and get a little flexible and work through that. Environmental laws were started to be passed in the 70s and continued on to the 80s and 90s. Engineers didn't throw their hands up and stop building things. They were flexible. They worked through it. They generated new revenue streams. Paratransit is too expensive, which I always find funny because everything we do is expensive. We don't do anything cheap, and so I'm curious as to why they draw the line at this particular service. And then there's the commentary. Well, it doesn't serve that many people, and it's true. It's a niche type of system, but there are more people who need accessible transit than need the bicycle facilities that we see popping up everywhere. So that argument falls apart pretty quickly. And then I'd like to transition to Russell, and I think I got this quote from him, and it was supposed to be a minimum, but it seems to be used as a maximum.
Yeah, thanks, John. So a lot of what we're talking about here, it is deep. I think it's deeply entrenched in both the advocacy communities and the transit providing, the provider communities as well. It's interesting when we first started our conversation, when I first started talking with John, and he said, advocacy, these large advocacy organizations aren't including people with disabilities and older adults. I just kind of went, what? Because so a little bit of background about me. Prior to my role here at CFILC, I was the director of advocacy at Resources for Independent Living, the independent living center serving Sacramento and Yolo counties. And for many, 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 many years prior to that, close to a decade, I was involved with Dogfight, which stands for Disability Organizing Group for Initiating Total Equality, a advocacy group started at Resources for Independent Living. And it was baffling to me because my first kind of exposure to disability community advocacy was in the space of transportation and housing. Those were like the two real areas that everyone was very active in. We were showing up at board meetings for our transit provider, Regional Transit, even eventually expanding to showing up at our COG meetings, Council of Governments meetings, COG. And so it was interesting. And then, then he explained what some of these organizations are, and they're kind of like they're the advocacy groups that advocate for what the transit future should look like for, kind of in the dreamy world picture way. And I think, what's unfortunate is that people with disabilities and older adults are never in those conversations, historically, whenever we have, one of the things that kept coming up as we were putting this together, I was like, we could talk about transportation. We could also talk about the new push for carbon neutrality and kind of the climate justice world, and how, once again, disability and older adults kind of have to push their way in and aren't being seen in those spaces, really honestly. So it's kind of I think the ADA kind of set up a well-intentioned initial approach, right? Demanding access to transportation systems that were largely dated and were ignoring the needs of older adults and people with disabilities completely. So there was a separate approach created, right? And we know historically from civil rights movements that this is the wrong thing to do almost 100% of the time. And here we are 30 plus years later, seeing that paratransit programs and others provide much needed service to people with disabilities and older adults who can't access conventional public transportation, for example. But what it's also done is it's made that a separate lane. So it's like the only avenue, even though there are requirements that public transportation providers be 100%, ADA compliant, right? So a lot of what John said is not shocking to me at all. And, the fact that it's largely exactly an unfunded mandate. So the ADA enforcement falls on individuals to enforce. And then we always just hear the same things in paratransit worlds that we do in public conventional transit, is that, it doesn't make any money, it costs too much money, doesn't serve many people. And, the whole convention of this was supposed to be a floor, not the ceiling, that's kind of so big in our work is these laws and such set a bottom. They don't set the top end of what's possible.
Great, thank you. Thanks, Russell.
Thanks.
And so moving on to the last slide in terms of why progress is so elusive, and that is it was a formal study conducted by an organization called, you see it here, the Transit Cooperative Research Program. It's a think tank wonky group that's an extension of the National Academy of Sciences. They had developed a study on how to improve accessible transit. You see coordination there again, in that. But the very first section they had under barriers was politics. And it was just, they were very blunt about it. It's like, this is a political problem. It's not a technical problem. It's politics. And politics comes into it because of the balkanized transportation service. So many different competing agencies, most with their own elected board and representatives, all with revenue streams to protect. Inevitably, it gets political. So I want to get current here, and the organizers asked that we touch on the master plan on aging, and the stakeholder advisory committee invited me to contribute during the transportation dialogue. And I understand that the master plan on aging is much broader than transportation, but I am just focusing on that. And I'm gonna focus on what we recommended in terms of the systemic improvement. And that was the big recommendation. There were smaller programs and recommendations that were discussed, but I'm going to focus on the systemic one. I'll touch on some of the other issues in the master plan on aging, but again, I'll just get right into it. What we focused on, the systemic improvement, was to expand the mechanism that I mentioned a little bit earlier today. It's the Consolidated Transportation Services Agency Mechanism, CTSA. A very cumbersome name, and it's been around a long time. It was established in the 1970s as a part of the Social Services Transportation Act. And so what we proposed was to fund these mechanisms, because they are not funded right now, and to expand their authority, to sort of modernize their authority. We included sort of walkability issues, those sorts of things. And so that was our big proposal, and we fleshed it out. We got pretty specific in terms of the specifics of the language change and the policy change, and even I think we had some suggested revenue streams. And what was included, CTSA recommendation was not included, not even referenced, not mentioned at all. And so some smaller programs were listed. I'll get to those in a bit, just to touch on them for the sake of completeness. But even those included in the transportation section were really bracketed with very permissive language, promote, encourage, those sorts of things. And so those were the smaller recommendations. And then real quickly up to the CTSA recommendation, we made that recommendation because the issue's been studied to death. There's no need to study it more. The recommendations have been the same for decades. And we knew we didn't have the bandwidth to propose some new grand scheme. The recommendations haven't changed, and we weren't going to seek approval for some new paradigm shifting mechanism. We just wanted to rely on what was already in statute. So what was included in the master plan? Again, I'm going to just walk through these pretty briefly, and improve walking circumstances through certain programs, safety issues, lower speed limits, key to increasing safety, conventional bus, making that more affordable, expansion of bus stops, and then there's some other flexible transit, driver safety education training, community walkability, those sorts of things. Those are some of the smaller ones that were included in the master plan on aging. And so, but I do want to emphasize that the CTSA model that we recommended, because, and I realize that we're just getting into the implementation phase of the master plan on aging right now, but the CTSA recommendation would have helped all of these implement these other recommendations. It could have been the mechanism by which the advocacy would have taken hold. And so how do we move ahead? The organizers asked us to describe how participants can expand these options. And if the preceding slides didn't make it clear, it's not going to be an easy task. I think we should model our efforts after a recent success, and that is the inclusion of bicycles in the mainstream transportation planning. And there wasn't anything special about their approach. It ended up being pressure from constituents and advocacy organizations. Traditional transportation engineering folks, and specifically Caltrans, did not take bicycle transportation seriously by any stretch. There's outright opposition. And if you look around, what we see now is as I mentioned earlier, these facilities popping up. So I think we need to take lead from them. And then there wasn't anything special, as I said. It was pressure from advocates who were, and I think this is key, particularly to this group that we're speaking to right now, these advocates were outside the mainstream transportation system. And I do think that healthcare folks are going to need to engage to change the transportation system. That was another recommendation, actually, that the stakeholder group on the master plan recommended, that we really needed to take some of the authority out of the transportation system. Changes began modestly. You had basically an executive order within Caltrans. They developed funding programs, which is what we want to get to. And then the concept was finally memorialized in statute as the 2008 Complete Streets Act. And so, again, I think we need to take a page out of that. So how do we move ahead? Exactly how? I think we need legislation. Just like the bicyclists and pedestrians got the Complete Streets Act, I think that we need an accessible transportation act. This would allow older persons and persons with disabilities, in the first instance, to not age out of the transportation system, and in the second instance, to be able to have a transportation system that actually, meets their needs, which it never really has. And so, I think we should fund and empower the Consolidated Transportation Services Agency. It's a systemic solution to fix a systemic problem. And, I think really that's what we need. And I'm not sure the organizers had in mind when they said, well, tell folks how they can help improve transportation services. I don't know if they had in mind such a grand proposal. New legislation of this magnitude is significant, but I have seen what happens to incremental efforts, minor efforts to tweak it. They just get rolled over in this larger transportation funding machine. And even in sort of the structured sanction processes like the master plan on aging process, we participated and we gave good defensible recommendations, solid, and the master plan was silent on that proposal. So I do think we need new legislation. And so I really appreciate being given the opportunity to speak to this group. And to be honest, I think I'm out of runway relative to making progress within conventional transportation circles, and assistance from groups like this is going to be necessary to make any progress. And I'd be happy to help with any effort that is initiated, and I can answer questions offline or right now if we have the time. And that concludes my presentation. Russell, I didn't know if you had any closing comments.
Sure. Thanks, John. So just to conclude, a lot of this was a really eye-opening experience for me to work with John. Really fortunate to have been connected, and it certainly makes me think more deeply about what statewide transportation advocacy looks like for people with disabilities and older adults. It's fascinating to kind of uncover the aha moment where you're like, this is why things are like they are. And John has done a phenomenal job at just being able to connect all of these things from his vantage point within, transportation planning. And I think it really kind of falls on us as a community now to really, start demanding our seats at the table, in the spaces that are different than the grassroots. It's so funny because I always feel like change happens, on the local level in the communities and whatnot. But so much of this conversation that is driven is happening at a statewide level. And the master plan on aging was a great opportunity to envision a really rich future for all people with disabilities and older adults. And we're even seeing now, that we need to push for additionally a master plan on disability as well. Not because we were completely left out of the master plan for aging, but because there are so many unaddressed things, so many unaddressed issues. But the good news is that whenever we talk about things like the master plan, we can say, here's how to set things right. And while we may not have gotten, or seen much on transportation in the original master plan for aging, we're now in an implementation phase. And it's absolutely right. John is saying that, the pedestrian and bicycling advocates were originally also shut out completely from transportation. And if you go back even further, public transportation kind of plays a very strange footnote when you talk about transportation, where the dominant narrative is still highways, freeways, and just individual car access. So there's a lot of work to do here. I'm going to stop though and open up for question and answer. And I'm really looking forward to kind of diving into some of the questions that you all may have.
Great, thanks to you both. And here's the contact information if folks want to follow up afterwards. Happy to provide that there. So we're going to go the first question from Debbie Toth. Debbie, your line should be unmuted.
Great, thank you. Can you hear me?
Yep.
Yay. Thank you, John and Russell. I said thank you in the Q&A, but this is, John, you just provided a 101 that probably most folks have never had access to understand the whole landscape. And I truly appreciate that. And for folks who don't know, John was my partner in helping put together the transportation piece through the Stakeholder Advisory Committee for the Master Plan for Aging that got completely dropped from the final plan. And I will say that, it's sad, it's frustrating, but it's nothing new to either of us. We've been working together for almost 20 years trying to make change. I will say that it is imperative that we elevate this as a top priority. And I think, John, if you could sort of explain, so the politics of it are that the transportation companies who provide ADA paratransit feel like when we say accessible transit, they're responsible for everything. And we need to be better about being clear. No, you're responsible for your ADA, but there's this volunteer driver stuff, this door-through-door stuff, this mobility management stuff, this, all of these different things. Why is it that a CTSA makes sense, particularly from a nonprofit point of view, when it comes to what they're trying to do, which is preserve their funding? So can you explain that a little bit?
Yeah,
is my question making sense?
I think it is. You specifically flagged CTSA, and I think this is going to actually answer your question, I hope, and then also a question that I see from Tatiana in the chat box, and that CTSA is extremely flexible. And so because there are so many different players in accessible transportation, they really vary by locality. And so you could have a strong nonprofit structure in one location, and then maybe not so much in a different area. So the CTSA is really just, it's a blanket designation. It can apply to a nonprofit. It can apply to a governmental agency, a county, for example, or a joint powers. And so so the CTSA is flexible enough to be able to dance around the needs of a certain community, and also what is also present. If you have strong public transit operators, then fine, you can set up the CTSA to sort of, sanction, their service as a standalone entity, and then you fill all the other gaps that you mentioned, Debbie, all the other various needs that aren't filled by ADA paratransit, which is very negative. And to Tatiana's question, the rural transportation, super important, and we did discuss that quite a bit in the master plan, and that's one reason why we recommended the CTSA, because of that flexibility. Because in a local area, you can set something up to serve those rural people that don't have the benefit, the mass transportation system, I think was the phrase she used. If you don't have that, you need to have that flexibility to provide that rural service. I think I mentioned that we're sort of awash in transportation resources. That probably doesn't apply in rural areas, and so I hope that answers the questions.
Great, thanks. We have one last question. I will squeeze this one in before we wrap up, from Jan Lamucci. Jan, your line should be open.
Thanks. You can hear me?
Yep.
Yes.
Okay, great. Thanks. I'm Jan Lamucci with Independent Living Center of Kern County, as well as a California senior legislative senator. So I think this was a big eye opener, both to John and Russell. And I see that the CSL could really help and be instrumental in legislatively in getting, these initiatives and improvements passed and get the attention throughout the whole state of California through all the CSL members. I know in Kern County, we have 3 paratransit systems with our Bakersfield, public transit, as well as a county and CTSA. But as you said, John, in the rural communities, it's still difficult. I mean, some of our bus stops in our rural areas are still just dirt roads, and it's an issue, and we need to, be on our state legislators, be on their butts, let's just say it that way, and get these improvements made. And I will bring that, as I said, I'm also on the Joint Rules Committee for CSL, so I'm going to bring this up, and I'll reach out to both of you.
Great, I welcome. That's the sort of coalition that we would need. I've worked with some CSL members in the past, and yeah, that would be a great addition to any coalition we build.
Okay,
thank you.
Yeah, thanks, Jan. I really look forward to that also. I think that the future of the CTSA may be that big body that we've looked for, where, really honestly, it kind of mirrors the goals of the master plan, right? Which is to consolidate, kind of create these bigger picture looks at things instead of the segmented approach that's kind of mishmashed. The history of transportation is complex, and a lot of times a lot of the players have been in it for many, many, many decades, maybe even a century in some cases. So it's important that we look at this new tool to ensure that there's equal provision for accessibility and older adults in all of them, and that it's not a fragmented system.
Well, great. I know we're right at time, so there may be more. You have their contact information. The presentations will also be available to folks who attended. So thank you everyone for attending today. Thank you so much, John and Russell, for all this great information. Lots of work to still do. So really helpful to kind of a call to action for folks here on and some really specific ways that we can move things forward. So thank you. I'll just quickly end by noting that the collaborative will not host a public webinar next month. We will resume our public webinar schedule on April 16th at 9:30 a.m. So be ready for information to come out about that. And then there will be a quarterly membership only meeting on March 19th. So for those collaborative members on the call, mark your calendars, and there will be more details to come on that. So again, thanks everybody. Really great session today. Lots of good information. Happy Friday, and we hope to see you all soon. Have a great day.
Thanks. Happy Friday, everyone.
Thanks all.
Thank you. Bye-bye.